My name is Kathleen Yao, and my colleague Ann Bode and I would like to present our review of literature for our capstone project, Implementation of a Fertility Preservation Program. We have based our capstone project on the 2006 American Society of Clinical Oncology's recommendations for fertility preservation. These recommendations include a risk assessment for infertility for patients of reproductive age and initiation of a discussion for fertility preservation options. These patients who are interested in fertility preservation should be referred to a fertility specialist or reproductive endocrinologist for an initial consult, and this consult would include discussing options such as risks, benefits, success rates, and costs of treatment. Currently, there are both male and female fertility preservation options that are available. These include sperm cryopreservation, embryo cryopreservation, conservative gynecological surgery, oophoropexy, and there have been updates to the current recommendations for investigational techniques, which we will discuss in the next slide. The ASCO and the American Society of Reproductive Medicine, or ASRM, have updated recommendations as of 2013, stating that cryopreservation of oocytes or eggs is no longer investigational and should be considered standard of practice for fertility preservation treatment options. For our problem statement, our research has identified that oncologists and reproductive endocrinologists must work in tandem to provide optimal care to newly diagnosed cancer patients. However, there might be certain healthcare practice barriers that inhibit this relationship, such as two very distinct areas of expertise, the lack of awareness and provision of appropriate patient education regarding fertility treatment options to patients of oncologists, a timely discussion and referral to reproductive endocrinologists by the oncologists, and patient barriers, which also include cost and decision making during a time of crisis. The purpose of our literature review was to evaluate if the implementation of a fertility preservation program will improve the following. Number one, healthcare provider referral rate to reproductive endocrinologists, demonstrating improvements in quality of care provided, and patient confidence in decision making, leading to decision satisfaction and increasing the quality of life scores of these patients. Thus, we have concluded on two clinical questions for our literature review. The first one is for healthcare providers who diagnose, treat, or care for newly diagnosed female cancer patients of reproductive age, what are the barriers and supportive factors to implementing fertility preservation care? And number two, do newly diagnosed patients with cancer who complete their initial fertility preservation consultation have increased confidence in decision making regarding future fertility options? The key concepts from our literature review for the relevant findings for clinical question number one regarding healthcare practice barriers and supportive factors for fertility preservation care and the implementation of it are, for this first portion regarding healthcare practice barriers, there are four barriers that we have recognized in the systematic literature review. The first one was approximately 40 to 100% of participants in the various studies that we had evaluated stated that they were unaware of the guidelines at the time of the study. Based off of the strength of the studies, we have demonstrated that this is a moderate recommendation. Demographic characteristics such as certain types of oncologists, whether it be surgical oncology, gynecological oncology, hematology, or provider affiliations with teaching hospitals and more senior level providers, were less likely to discuss fertility preservation options. This was a weak to moderate recommendation. healthcare provider attitudes, and the comfort in discussing fertility preservation and availability and the success of fertility preservation options influenced if fertility preservation was discussed at the time of cancer diagnosis. This was a moderate to strong recommendation, and patient and institutional barriers were identified by healthcare providers as barriers for discussing. And so these would include, patient socioeconomic status, perhaps age, institutional barriers such as a large university versus a small rural clinic. These impacted if the fertility preservation discussion was completed or recommended for treatment. And this was a moderate to strong recommendation. For institutional barriers, the patient barriers was a moderate recommendation. The supportive factors for implementing fertility preservation care that we've found in literature were three different components. One was increased provision of educational materials was a supportive factor. This was a weak recommendation. The timing of fertility preservation referral at the time of cancer diagnosis and before surgery, specifically breast surgery, this was a weak recommendation. And then this third component, I believe after the results do come out, hopefully it will be a supportive factor, but as of now, this is an ongoing study, and so there hasn't been anything published regarding the results of it. But extensive training and education of oncology nurses on fertility preservation, I would hope and propose that it would be a supportive factor to implementation of the fertility preservation discussion.
Now picking up with the second clinical question regarding if newly diagnosed patients with cancer who complete their fertility preservation consultation have increased confidence in their decision making regarding their fertility options. The key findings from this portion of the literature review included three aspects. The first being timing of the information, that women were requesting timely information and referral at the time of surgery or as soon before they were expected to begin gonadotoxic therapy, so that they would have time to get their information and make their decision. They wanted in-person consultation as well as written information for follow-up, and they wanted the opportunity to be able to include a support person or a partner in the information reception so that that person could also help with the decision making. The second part included the helpfulness of decision aids. To have a decision aid that helped with values clarification and a logical sequence of processing the information was very helpful in making a satisfactory decision. In the process of the literature search, I found that significant disparities existed in terms of who got referred and who didn't. So there's a large need for increased awareness that fertility preservation options should be offered to all patients. And this will be assisted if the general public has more information regarding this option. The third aspect was the psychological benefits of the fertility preservation consultation, irrespective of whether the choice is made to go forward with fertility preservation. The whole concept of thinking about life after the cancer treatment is over provided hope and wellness, and even some research showed an increased ability to be able to cope with the cancer treatment. And just to review the timeline for our project, we began in June of this year with the idea development and getting our Heartland team together to talk about the project plans and who would play what role. And later in the summer, we met with the oncotherapists that will help the patients with their decision making. That is through the Integrative Center for Fertility here in Omaha. and there are 2 to 3 fertility therapists that will be meeting with the patients individually at the time or immediately after the fertility preservation consultation to help them process and to make decisions and provide ongoing support. We completed our proposal statement in July and began the literature review at that time also, formulating our PICO statements and focusing our questions. The literature review was completed in late September, and then we began the translation of evidence into practice plan in October. We will begin now working on choosing the tools that we will use as our intervention to assess both physician learning and referral, as well as patient learning and satisfaction with their decision making and quality of life after the cancer treatment. We will apply for the IRB application early in 2015, and hopefully by the summer of 2015 we will be recruiting subjects, with hopefully completing data analysis and writing up the results about a year from right now. So to recap the lessons learned from the review of the literature, there is definitely a lack of awareness of providers regarding the availability and the guidelines of the need to provide fertility preservation options to all females prior to cancer treatment if they are in their reproductive years. Certain healthcare provider demographics and attitudes, as well as patient and institutional attributes, lead to the disparities in which women are referred and which women aren't. There's significant disparities in the patient population. Those who are in their 20s to early 30s tend to get referred more often, especially if it seems that they would have the financial ability to pay for it. Urban options get more frequent referrals because the availability of care is closer by. Patients are not aware of the availability of fertility preservation treatment options pretty much across the board, and they're also not aware that there is assistance available to offset the costs of treatment as needed. There is a significant need for education for both the providers, nurses, patients, and the general public. If I had to summarize it into one statement, that would be the biggest one, I think. There is benefit to considering and making a decision regarding fertility preservation options that are much larger than the choice made to pursue fertility preservation.